want to talk particularly about patient-centred care and how this kind of technology can help. We've got an absolutely terrific panel with us. So to take the meta view, the eagle view, we've got Noel Gordon there, who's chairman of NHS Digital. Some of you will know that as HSCIC as was. We then have Dr. Harpreet Sood to do the clinician-centred approach, and he's Associate Chief Clinical Information Officer at NHS England. And then we have Craig Rhodes. Craig is industry lead on health and life sciences at NVIDIA. NVIDIA you will know for gaming, but actually it's the software and hardware behind a lot of AI. So let's hear from you first of all, Noel. What are your thoughts?
Well, maybe I can begin with a couple of perspectives on NHS and its transformation journey. So, as Tony described, the NHS started out transforming itself 4 or 5 years ago with a 5-year forward view. And the first perspective that I had was that technology was never really seen as our fourth factor of production. And the significance of that insight is that when we look at land, labor, and capital in our health system, we're highly constrained by land, not enough of it in the right place. We're highly constrained by the speed at which we can accelerate the workforce, both in terms of size and skill, and we're highly constrained in terms of capital. So my mission coming into the NHS was to give technology parity of esteem with the 3 other factors of production. Second point I'd make that follows from that is that technology really, in our world, needs to be seen as the accelerator that gives us escape velocity. And escape velocity in transforming the topology of how we design and deliver health and care. A lot of the new ideas in the way we deliver health through STPs and ACOs and ICSs, personalized medicine, and the use of new tools is heavily dependent on fourth industrial revolution technologies, AI, IoT, sensors, and data in particular. So the escape velocity we need, and most healthcare systems in the world need, will come from the emergence of the fourth generation technologies, fourth industrial revolution. To make that happen, we need good access, good data, and good tools to enable clinicians and patients to access a lot of the technologies that we're developing. So we've been on a program for the last 2 years to build the platforms that will allow clinicians, AI developers, medtech entrepreneurs, clinical entrepreneurs, research organizations, to get better access and easier access to publicly held information, B, to manage and streamline some of the protocols under which that access is given, and thirdly, to play a much more proactive role, and this is where Tony Young's program with clinical entrepreneurs has been really quite foundational for the NHS, for us to be much more proactive in building a medtech economy. Because as the original Health and Social Care Act foresaw, health goes with wealth. And when you look at the scale of the SME medtech sector in the UK, I saw an article in the Standard last night that said roughly it contributes about 21 billion to GDP, and possibly in the region of 500,000 medtech startups around the country in different areas. So we've got an obligation, if not a responsibility, to be able to enable the medtech sector to come to life. But I always remember a wonderful quote from a French philosopher, which I think about a lot in the NHS. And it basically says a new truth goes through 3 stages. First stage of a new truth is that it's violently denied. The second stage is that it's aggressively opposed. And the third stage is it's deemed to be self-evident. And I sometimes think that our mission with AI and our mission with the fourth factor of production is just coming out of the second stage of being aggressively opposed and will quite soon be deemed to be self-evident. But as Tony said, there are a couple of things we have to get right. We have to get privacy right, we have to get ethics right. As one great Hong Kong clinician said to me over dinner last week, we are not yet certain the entirety of medicine can be converted to zeros and ones. There is something in the middle, the grey area of judgment, which clinicians apply, excuse me, which we have to think about carefully. 3 areas that are most attractive to us at the moment: aging, all help that we can get in terms of the age demographics and the consequential diseases that flow from that, incredibly powerful. 2, mental health, especially young and adolescent mental health, but also aging mental health. And thirdly, our great new diseases of obesity and diabetes. Our 3 factors of production cannot change the business model of the NHS fast enough to cope with the demographic profile and the disease profile, disease burden that we're inheriting. So that's the role of AI.
Thank you so much. Can I come to you now, Harpreet? Because if we're ready now to embrace this, what are we looking at in terms of barriers? You mentioned, Noel, privacy, security. What's worrying you at NHS England?
No, thank you, Vivienne. So, kind of 2 things that we've been looking at in particular over at NHS England is firstly the issue of workforce. And I think, both Tony and Noel and I touched upon this, is that developing the technology is one thing, but how do we actually implement this in a real-world setting? How do we actually get this embedded into clinical pathways to think about how do we integrate this into our workflows? So, similar to the Clinical Entrepreneurs Programme, a year ago we launched the NHS Digital Academy, which was about upskilling and developing a cadre of professionals that really understood what does it mean by digital transformation. How do we take those exciting technology that is being implemented and actually really think about incorporating it in our day-to-day fashion. What we can't assume is that clinicians in particular or managers will just wake up one morning and say, right, it's time to implement AI, it's time to implement this technology. We need to give them the skills and the tools to do that. This morning a report came out that, we are currently a workforce shortage of about 110,000, and that will probably double in the next 10 years to over 200,000 vacancies across the NHS. So we need to think about how do we firstly upskill our workforce, but then also give them the tools and the skills to do this transformation. So that's the kind of the first big piece of work that we're thinking about. And so Eric Topol, who's an eminent physician in West Coast, was asked by the previous Secretary of State to come and help us think through that, in that with the advancements of AI, genomics and digital medicine, how is the role of the clinician changing, but how is the training to that clinician also changing? So medical school is one thing, but postgraduate training, how do we apply new skills, how do we give those new skills to individuals is a key aspect of it. And we hope to put our final recommendations out later this year, but on the back of that, see lots of new ways of training and developing our clinical workforce, which will be fundamental to how to think about the implementation journey for these technologies. The second crucial point that we are working on, and I briefly mentioned this yesterday at the workshop, is that last week we launched something called the Code of Conduct for Data-Driven Innovations and Intelligent Algorithms. And the purpose really behind this is that today we don't really have a rules of engagement to say to innovators, industry, developers, researchers, what is it that we can do to ensure that we are creating safe, open, transparent algorithms in order for us to maintain the trust between the clinician and the patient, but also amongst the clinical community and society in general. And this code, which has 10 principles, really looks at things like how are we defining the user need? How do we ensure we get the right value proposition? What is our commercial plan? What data are we actually using? What is the limitation of that data? How are we ensuring continuous performance and learning feedback in the algorithms that we're developing? how are we showing evidence and effectiveness? And even though this is initial code and this is open for consultation, so I encourage all of you in the audience today to go and look at this and give us the feedback, we hope to publish the final version later this year, and we see this as one step towards a regulatory framework that will allow us to ensure that openness, that transparency, and factor in the ethics that we are talking about, but also really be a world leader in saying developing technology is one thing, but what we don't want to do is ensure more inequality, ensure that we haven't thought about fairness, we haven't removed this bias, we haven't thought about transparency, because ultimately it is about that clinician-patient relationship, and if we don't get that right, we think we will go a lot further backwards than we actually go forwards.
Thanks very much. Now, Craig, safe and secure is something that you're very concerned about at NVIDIA. Tell us a bit more about your thoughts in this area.
Yeah, I think one point is I really hope that transition from the French philosophical person goes quite quickly, because, you know, the idea of making safe and secure artificial intelligence, it's not just from a patient's perspective, but it's the trust of the clinicians as well. So one of the things that, NVIDIA, and we're seeing huge growth in the adoption of technologies to drive AI, and that's probably part of the reason why I'm here today, and to look at what's going on in this space. But NVIDIA really kind of focused on looking within the hospitals and the research centres about what's going on and how that's working. We're seeing massive increase in people wanting to be informed and engage. But with that, we're seeing huge challenges that a lot of those engagements are fairly siloed based. You know, you've got a research trust, university hospitals collaborating together, but you've got many of those around the NHS. So one of the concerns and the challenges that I see is the kind of the governance and the provenance of things like artificial intelligence, especially around the algorithm development, is how do you inform, and I think Tony touched on it this morning, where ethnic kind of race, monetary matter, how much money you're earning doesn't matter. The kind of care that you're going to get is consistent across the NHS. So those things aren't embedded within the algorithm development, and I think that's a concern. I worked previously with a company called Mapper Medicine, and we had this idea of creating provenance behind clinical pathways. And again, to your point about where do we slot AI into the clinical pathway, is absolutely essential to know what are we doing, when are we doing it, making sure that the pathologists, the radiologists, the consultants don't feel like they're being removed from that process. Is actually they're part of the process, and actually part of making that process work and engaging with the technology, and we're not taking a step back. I do think we're on a kind of a point where it's going to work or there's going to be backlash, and we're at that point where we need to make sure that it works, and it works really well, but that we join up, especially with an organisation like the NHS, that we join those developments up together so we can learn from each other and the algorithms learn from each other, because that's what they're there to be put forward.
I mean, there needs to obviously be transparency about algorithms, but there's obviously a commercial sensitivity about algorithms. How far can the medtech industry work as one? Because there's a million startups. How can they work as one to make sure that they're all committed to the same ideals?
Yeah, I think that's the million-dollar question, isn't it? That there's a lot of organisations, and DeepMind, obviously very well, is publishing their algorithm, and I think there is a point of the intellectual property behind the algorithms. It's a certain point where we know that the provenance to this part of it belongs to that organisation, and they should be numerated for that. But there should be a part of that algorithm and that AI that is clinically that has clinical input into it, and that should not be beholden to a certain company. That clinical input should be available for clinical reviews and clinical input at any point in the time. So if we develop something in Coventry and Warwick Trust around lung cancer, that it can be used down in South London at King's Hospital, that they can review what's been put in from a clinical efficacy perspective, and then say, yeah, we agree with this, and we can practice in the same way. But there are fundamentals part of that algorithm that still belong to if an organisation's developed it, because they're going to want to be paid at the end of the day. They're putting resources, time and effort and technology into development.
But perhaps this is more of a business model like mobile phones, where you get the first mover advantage in that, you know, you're out there with your algorithm and other people are going to have trouble catching up with you. But it has to be transparent, so it has to be out there in much way that, you know, in a mobile phone, you develop something new, knowing perfectly well that it's going to be copied everywhere within 6 months. But at least that makes it, that's what, you know, where you're at. But I was wondering with Noel whether we would get ourselves into trouble in AI in the way that we have with other systems, whereby the NHS is locked down into systems that you are not interoperable between one trust and another, in the way that we've seen with a lot of legacy computer systems, for instance. How are we going to avoid that in the NHS, repeating the mistakes we've made with other technology introductions?
A very eminent Indian physician said to me about 6 months ago that his vision is that within a few years it will be mandatory for every physician to take a second opinion from a robot. And that struck me as really quite a profound concept, and really quite an interesting North Star. So if we keep the end in mind, there are 2 or 3 steps along the road to get to that point, if that's a desirable social point. First is Harpreet's mention of the AI Code of Conduct, which is really quite an extraordinary thing for us to have produced, because it sets out, I think for the first time, what we expect AI developers to conform to in order to create some convergence, but still stimulate the marketplace, which we have to do. Secondly, we are dealing with the legacy of a huge IT estate, which was developed in a pseudo-democratic way over the last 20 years.
163 different IT systems in every NHS trust is what I've heard.
Quite possibly. The point of the story is not to suggest that we are going to have standardization of technology, but we are going to have interoperability of technology. And that is important because we do need smart people to come up with new solutions without it being always a case of going to multinationals for the answer. And we are acutely conscious of creating duopolies. We are acutely conscious of creating oligopolistic structures in the medtech, in the IT, health and care IT technology space. So we do want to stimulate the marketplace to help us get a much more diversified partnering structure. Thirdly, we have to rely on clinicians being the sort of lighthouse here, because people like me and people who run things in the NHS are not always people best equipped to make acute ethical and moral and clinical judgments about how technology should be used. So what Harpreet's developing with the clinical informatics program is designed to build a new cadre of clinical informaticists that will be our guiding light around which technologies make most sense in which settings. So those 3 things are really the pillars of how we're approaching it. But we absolutely do not want to go back to a world where our data and the functionality of our IT is locked in silos. We have to move away from that because the operating model of the NHS requires huge amounts of integrated care to be delivered. And we can't do that in silo structures.
And just on that point, actually, and wearing my clinical hat on now, we know that clinicians, when making decisions, take at face value what they get told by the health IT system. And the reason I say that is we had a classic example.
Although you never do that for patients.
No, in terms of...
When you ask them how much do they drink, you always double it.
Yeah. Okay. Well, that's because patients tend to veer the truth a little bit. But anyway, so going back to, we know that's happening because we have seen a great example of this happen where an algorithm that has been put together by one of our health IT vendors has mistakenly mapped a wrong algorithm. So what was being prescribed to certain people shouldn't have been prescribed, i.e. statins were given to people that shouldn't have been on statins and vice versa. Those that should have had statins just didn't get statins. And the question always then arises, well, where does the accountability sit with that? Is it with the clinician who has been prescribing based on what they have been told, or is it for the individual who actually developed the algorithm? Now, this is a very simple algorithm that has been put together. Now, if you think of the machine learning algorithms that we will be developing and are developing that are continuously learning, where on that spectrum does the accountability sit, and where does the role of the clinician sit? So that's why it's fundamentally important that many of our clinicians in particular start really understanding what are some of the basics around this and what do we mean on this, because just like we use NICE guidance today to help us provide evidence-based care, in the near future and very soon we will be having these algorithms that will be providing us with that, but we will need to understand and explain to our patients how do we get to that certain decision for them to become like that. But then if we don't understand it and we get fibbed by these algorithms, it will be a big concern, because today we're talking about all the exciting things, but the thing that we are not really focusing on is the safety and thinking about what if things go wrong. And I think we need to have a rounded conversation on that front.
So is the NHS ready? Yes, the NHS is ready to receive AI, but these basic building blocks have to be put in place, because if they're not put in place, then the potential for public and clinician backlash is very great. Can I ask you whether you think that there will be a time when data science will be an obligatory part of a medical degree?
Absolutely, and I think that's what we're hoping for. And part of the total review is exactly that: is that how do we encourage now to push medical schools, nursing schools, allied health professionals to think about this during undergraduate training, but also for postgraduates. What is it that we're doing? Now, we're not expecting everyone to do this. Not everyone wants to become a clinical data scientist, or not everyone wants to become a CCIO, but I'm assuming most people in the audience who are clinicians may want to. But the thing we have to ask ourselves is, what is it we're giving them to think about this? And, someone said to me, if AI was termed as applied statistics, we will all run away, because during medical school, I know for sure that when it came to epidemiology and statistics, I was the last person to go in because we just frankly didn't understand it. And the question now arises that if that becomes part of mainstream medicine, and it will very soon, we need to really revisit those books and say to ourselves, okay, how do we understand the area under the curve? What do we mean by sensitivity, specificity? What is the p-value? What is the maths behind this? Because that is what it will be determining how certain outputs are being put forward. And that's why I think communities like this are really important to help drive that agenda and to start creating a cadre of individuals that can really help other clinicians understand why this is becoming important.
I mean, clinician acceptability is hugely important in this area, and doctors are very well aware that, how many clinicians have we got here? Lots of you, hello. But medicine is as much an art as it is a science, and I wonder whether actually what we're selecting for at the moment is possibly not suited to our future. In other words, what we're selecting for at the moment are doctors with, or potential doctors with very high levels of intelligence, able to assimilate all this knowledge. But actually with an AI-enabled future, what we'll have is we'll need doctors with empathy, with really strong clinical skills to be able to go through some of the choices that are thrown up by AI systems with the patient. So in some ways, I don't know whether you think this, Craig or Noel, but whether this actually takes us back to a type of medicine that was, the Dr. Finlay of the past. In case you don't, Dr. Finlay, because you're not far too young, he was this country doctor that knew every one of his patients and had this kind of bedside manner. Is that actually going to be enabled by AI?
So there are a couple of concepts in play. One is that technologies will help us move from one to one to one to many, and back to one-to-one. So when we think about the future of personalized medicine, that is ultimately a new incarnation of one-to-one healthcare delivery. Secondly, it's not just at the point of care where AI is going to help us. It's going to be around understanding population-based health in a very different way, and particularly some of the situational aspects of healthcare and well-being, which are really, really important, how you plan and deliver NHS services. Place-based, which is a much different concept of how we think about integrated care in smaller units. Thirdly, around huge back-office factory-type functions where there are huge numbers of repetitive tasks. And, you know, if you think about a shared service for radiology and pathology, it requires, at the moment, huge levels of skill, but it's fundamentally a production line, and it's a repetitive process, where at the moment we're using incredibly skilled people to diagnose in radiology and pathology on a one-to-one model. Actually, if you look at the shared services we've set up in the Midlands, for example, around MRAD and a couple of other places, they are largely shared service facilities which are using AI-based technologies to create a solution at low cost with reasonably high degrees of accuracy, readings which we just would not otherwise have the workforce to be able to staff. So I take a sort of broad view of where we can use AI in different parts of our value chain, our supply chain, and it's not always about replacing the clinician who is in front of the patient.
No, clearly, but it's the things that go, the patient actually doesn't care what goes on behind the scenes, effectively. It's about AI delivering all that information to the clinician in a much more packaged form for then the clinician to be able to interpret for the patient. Craig?
So I was just going to say, I totally agree. I think try and take the low-hanging fruit, and radiology, pathology are great examples of where you can go in and, you know, pathologists are seeing patients that just don't have cancer. I think there's a case, Coventry Morrick, I mentioned before, having 40% of their patients coming in for suspected lung cancer, haven't got lung cancer. Now, can you get those patients triaged to the back of the queue and reprioritise those patients that need care very quickly in a fairly simple way? Well, AI can help the pathologist be able to do that without taking control of their work. So there are some simple things that we're seeing, certainly from NVIDIA's perspective and the engagements that we're having, commonalities that people are asking, can it just do this? This is all we want it to do. We don't want it to kind of tell us what the precise diagnosis, what medicine, but we want to be able to do this type of triage. And doing some of that operational type work and not the clinical aspect to it will bring into play the AI without the fear that it's taking over the clinical practice or taking over the clinical workflow or the clinical process. So I think that's an easy step to make, and then you start to look at, you know, we started talking about genomics, some of the stuff that's going on with deep variant calling and deep learning within genomics, which is much more complex. And I know the NLP's up there, but, you know, NLP trying to, you know, you mentioned 12, 13, 1,400 systems. There's probably 600, 700 repositories of data in a large trust. Trying to apply natural language processing to all of those repositories and make sense of them is a very, very complex task, which will take a lot of people, a lot of time and a lot of effort. So I think there are these things to choose a pathway through to AI first that gets engagement from the clinical community, as well as starts to get the patients to understand that these are things that are going to start, without going for those really big things that are going to take years and years that will ultimately be complex. But still, we're not too clear on how we're going to apply that. And I think that kind of NLP, the genomics, we're still starting just to touch on those, whereas image analysis is a fairly well understood, you know, NVIDIA's been doing that for 10 years, since the cat and dogs slide that was up recently, you know, with the ImageNet competition.
So finally, I guess, you know, we obviously go for the low-hanging fruit, but actually a key point to make is about clinical pathways, is that if AI is not embedded in a clinical pathway, then it's really not going to succeed. And I think possibly that's where developers need to be absolutely sure that they have the clinical input, because otherwise this shiny thing arriving that doesn't actually fit into the system isn't going to work.
Yeah. No, and totally agree. And just reflecting on what was said earlier, so, you know, today when I'm even seeing patients clinically, I get a lot of patients that come and say, you know, I tried 111, I tried this virtual thing, but I thought I'll come in anyway just to make sure I'm all right, because I thought I'll see a doctor in person. Now, that's all well and good, and happy to see this individual, but this individual has gone through 3 different interfaces before it's come to me. So not only do we need to ensure that we develop the trust between how the algorithm or whatever we are creating is, the trust is ensured in that, but we also need to ensure that there's trust that whatever they're using works, because often, you know, a lot of people, technology doesn't work, and they've seen, and we've seen even in the system where technology doesn't function as it should do. So maintaining both trusts and how we do that is really important on that part. And like I said, you know, today we're still seeing very point solutions, so we take a whole pathway and we come in and really fix one point of it, but everything else stays the same. And if we're really thinking about transformation, we need to really reimagine the way we do things. And I think that's the really hard part, is how do we really think about the whole pathway from end to end. So if someone's just been diagnosed with diabetes all the way to the fact that they need chronic disease management, rather than just fixing the fact that they will get the insulin at the right time, how do we think about the whole circle of things? Because that's where we'll start seeing the real impact. The point solution on its own will have a certain impact, but if everything else is doing the same, it will be very hard to see the real benefits of what we're trying to achieve.
Thank you all very much. So I think what I take from that is that for it to be patient-centred, for AI to succeed as it should, you need to make sure that the rules are, and the standards are in place. You need it to properly address clinical problems that really need addressing, rather than the thing that you think is rather whizzy. And you need to have some early wins, some early clear wins that are really obvious to patients, because I think it's those early wins that will give people the confidence that AI is a tool that is for their benefit, and not just, as I suspect some people might see, as a means of saving money or earning a lot of profit for particular companies.
Absolutely.
So thank you all very much indeed. I'm sorry we didn't have time to open it to questions, but we were running a little over. And would you thank our panel?